Welcome to the Cleveland Center for Eating Disorders three-part blogging series on the diagnosis, management, and treatment of eating disorders. We're here with Dr. Lucene Wisniewski, the Clinical Director of CCED. Dr. Wisniewski, can you discuss an overview of the diagnostic criteria to meet anorexia, bulimia, and EDNOS?
Sure, Sarah, thank you. First, I should preface with the diagnostic criteria that I will describe to you is based on the DSM-4 manual, which is the Diagnostic and Statistical Manual, the 4th edition, which is the Bible of psychologists and psychiatrists in terms of making diagnoses. The DSM-5 will be coming out within the next year, which will have some slight changes to these diagnoses. But since they're not out yet, I will discuss really the DSM-4. First thing you should know is that eating disorder behavior really runs on a continuum from not diagnosable, funny, what I call funny eating, all the way up to diagnosable disorder. And really, if there is problematic eating that is resulting in distress and impairment, it requires treatment, even if it doesn't fit nicely into one of the categories that I will describe to you now. Anorexia nervosa is characterized by, first and foremost, a refusal to maintain a minimum body weight. And that can be evaluated in a couple different ways. First is by body mass index. A BMI of 17.5 or less meets diagnostic criteria for anorexia, or percentage of ideal body weight. 85% of ideal body weight or less is the diagnostic cutoff for anorexia nervosa. And it's not just this refusal to maintain a minimum body weight that is the hallmark of anorexia. These are folks that often have an intense fear of gaining weight or becoming fat, even though they're in an emaciated form. They have a disturbance of their weight and shape. They see themselves as actually bigger than they are. And in females, they experience amenorrhea, which is a sign that the body does not have enough food and fat to be able to produce children. Obviously, this is a problem when you're talking about boys in terms of the diagnostic criteria, and this is likely one of the criteria that will not be held up in the next iteration of the DSM, but it is there now. There are two subtypes of anorexia, purging and non-purging type. The non-purging type is the one I think that most people think of when they think of people with anorexia nervosa. These are purely restricting. And then we have the binge eating and purging subtype, where they may restrict significantly but then also engage in binging and purging. This is the one place that many professionals mistakenly give the diagnosis of bulimia nervosa. And so please be aware that if the person's body weight meets criteria for anorexia, that the diagnosis of anorexia trumps the diagnosis of bulimia, even in the presence of binging and purging. When we talk about bulimia nervosa, the hallmark of bulimia is the binge. The word binge is something that gets used in common parlance often, so being able to really understand what we mean by binge is important. Diagnostically, what we mean by binge is eating a large amount of food in a specific period of time and including the experience of a loss of control. The person has to have felt that they couldn't have stopped even if they wanted to. And then after the binge, that there needs, in order to meet the criteria for bulimia nervosa, there needs to be recurrent inappropriate compensatory behaviors, purging, fasting, excessive exercise. Right now there is a frequency criteria that the binge eating needs to occur at least twice a week for a period of 3 months. This is one of the pieces that will likely change in the DSM-5 to a decreased frequency. And you should know that folks with bulimia nervosa often, to meet the diagnosis, have an experience that their self-evaluation is unduly influenced by their body weight and shape. The sun rises and sets on what their body weight is. And that, as I said earlier, this disturbance doesn't occur exclusively during an episode of anorexia nervosa. There are two subtypes of bulimia: the purging subtype, where the person binge eats and then purges in some way, and then the non-purging subtype, where they do binge eat but that their compensatory response is around severe restricting or excessive exercise. When we talk about eating disorder not otherwise specified, that's the catch-all phrase for people who have significant disturbances in their eating, but do not fall nicely into anorexia or bulimia. There is currently a subtype under EDNOS that for the last 10 years or so has been under research exploration, and that's binge eating disorder. Those are people who engage in binge eating but do not also engage in any sort of regular compensatory response. Right now, the diagnosis of binge eating disorder falls under the diagnosis of EDNOS, though in the DSM-5 it will likely be its own diagnostic criteria.
How might eating disorders impact individuals both emotionally and physically in terms of medical complications?
You know, it's interesting to me that eating disorders negatively impact a wide area of functioning. So it impacts the person's individual well-being in relation to medically, which I'll get to in a minute. It impacts their interpersonal functioning. So for example, if someone is either struggling to eat or has issues around body image, they often will isolate themselves and have a lot of difficulty engaging in social interactions around food and eating. And it impacts their work functioning. These are folks who are more likely to become ill secondary to other problems. So I think that it's relevant to talk a little bit about, because we're assuming that some of you might be interested in the medical issues related to eating disorders, to talk a little bit about that. Semi-starvation, and you can see semi-starvation both in anorexia and in bulimia where there's severe restriction, it really affects most organ systems. So these patients will show up with constipation, significant cold intolerance, even in the summertime, bradycardia, abdominal distress, low blood pressure, and in really significant forms, the body will develop lanugo, which is a fine body hair, and it's the body's pathological attempt to keep itself warm. Anorexia can lead to anemia, kidney and heart problems, osteoporosis and osteopenia, as well as dental problems. So it really impacts a wide variety of physical function. The complications associated with bulimia nervosa are mostly associated with the self-induced vomiting aspect. And you can see a permanent loss of dental enamel on the teeth, in particular in the front backs of the teeth, salivary gland hypertrophy. Some people describe it as a chipmunk-like appearance. The salivary glands become swollen. Electrolyte disturbances that can be life-threatening, and cardiac and skeletal myopathies, in particular with the misuse of Ipecac, which is how Karen Carpenter died, for those of you who are old enough to remember Karen Carpenter. Laxative abuse can have problems with metabolic acidosis as well as permanent disruption of normal bowel functioning. And the binge eating itself can sometimes cause problems, although rarely result in gastric rupturing or esophageal tears. So there's quite a significant amount of medical complications associated with any of the eating disorders, which is why it's so important for any patient with an eating disorder to be monitored medically.
Thank you, Dr. Wisniewski. Can you discuss the comorbidity of eating disorders with other mental illnesses and how this may impact treatment? At least in tertiary care facilities, we rarely see patients who don't have comorbidities. Not to say that they aren't out there. For example, 50% of all patients with eating disorders will suffer from major depressive disorder. It seems to be slightly higher in bulimia nervosa than anorexia nervosa, but 50% is a big number. We see a lot of comorbid anxiety disorders in our patients, in particular OCD, obsessive-compulsive disorder, seems to be slightly higher in our patients with anorexia nervosa, and social phobia both seems to be a risk factor as well as a comorbidity for bulimia nervosa. Substance-related disorders we see almost exclusively with bulimia nervosa. We don't often see it in anorexia, but in patients with anorexia purging type, you may also see substance abuse. Now these things obviously very much impact the treatment. If you have someone who's depressed, it's unclear sometimes, is their depression secondary to malnutrition or is there an independent mood disorder on board? And the only way that you can figure out many of these issues is to treat the eating disorder first and then to see what happens. That being said,
many of these illnesses, when they're on board, significantly can get in the way of treating the eating disorder, and there's no data to suggest that treating any of these primarily will make the eating disorder better.
Thank you, Dr. Wisniewski. Please join us next week as we continue our 3-part blogging series on the diagnosis, management, and treatment of eating disorders. And don't forget to visit us online at www.eatingdisorderscleveland.org.